at any given point of time, last time Dr. Karthik said that even after 5-7 years, if the medial side gradually wears out or maybe stretches out, there is a risk of dislocation. So these are not common X-rays, but these are also not very uncommon. એક આગળ નીકળી ગયું, એક પાછળ નીકળી ગયું, પાછું આગળ, એક પાછળ. So we can see anterior, posterior. Not all my cases, but combination of our all very superior kind of. So I'll talk about this one specific patient of mine, 58-year-old female, osteoarthritis, BMI 28, normal, no comorbidity. We did stress views and confirmed that it's an AMOA. This was a post-operative X-ray. How much problem થયો હતો sir? Karthik sir, આ વાળો X-ray. Sirji, do you have any problems with this X-ray?
See, I think when we talk about bearing dislocation, lot of secrets lies in soft tissues. So a picture perfect X-ray and it still have a problem. So apparently AP X-ray is not dead AP, number one. Lateral is good.
What I have also understood is that Oxford no X-ray post-op ક્યારે સારો ના આવે.
IITV always check under
you have
IITV.
to check under IITV.
Agree.
It looks overcorrected.
This looks overcorrected. Yeah, all our this is also a very important point what Karthik made. Okay, if you do a CT scan of a patient and if it is only 2 or 3 degree of varus, and eventually when you do a uni, it would correct to a 0 degree alignment. So would you go ahead with the surgery or not? Because all of our patients are 3, 4, 5 degree of varus. When we do our uni, we don't want to intend to correct it, but eventually thodu correction thai jai. So these are our X-rays. He is right.
It will suffice.
Yeah?
It is good.
It's okay. It's okay, sir.
Yeah, this is fine.
Relatively okay.
Yeah.
Everything went very well. 6 months patient was fine. And one fine day, the history ke સામેણી થી નીચેથી પેલું વાળતા હતા અને that's how a popped up feeling appeared and the patient showed this X-ray to us. સુરતના patient હતા એટલે they went to other Surat doctors and somebody did a varus view and somebody did a valgus view and they made sure that our posterior dislocated થઈ જાય. So if you can see this one, exact bank posterior, the poly is bank posterior. So now as Chirag asked that my MCL is still okay, there has to be some component edge loading or something which led to this posterior dislocation. So I was in my mind thinking about how do I manage this situation where the MCL is going to be relatively okay, medial sides are okay, how do I remove this posterior poly?
So it comes out, I think, which is very rare. See, posterior dislocation is extremely rare. This is, I think, obese. So someone has not done a proper anti-impingement guide. So anterior distraction plus anterior displacement plus distraction is the only way this can dislocate posteriorly.
મેં જે કીધું સર સામેણી વાળતા
Impossible.
Not possible?
One another movement is that when we check the flexion gap and we check in the 90 degree or 100 degree of flexion, but we always should do proper balancing in extreme flexion. That is the thing, because
extreme flexion would it come anteriorly or posteriorly?
it will come anteriorly. It will come
એટલે
anteriorly.
આ વાળું થોડું અલગ હતું.
That is the thing.
This is different. Yes. Thicker on the posterior side.
Congruent.
Poly? ના ના કેમ લેટરલ એક્સમાં क्या देखा तो
Then what is the reason for posterior dislocation?
नहीं
Impingement.
हाइपर
Anterior
एक्सटेंशन
impingement, posterior
पेशेंट को
dislocation.
5 डिग्री हाइपर एक्सटेंशन
So whatever patient was telling me, maybe that could be not be the history. And as what I understood from Dr. Karthik's lecture, that it has to be some surgeon's fault or some surgeon's problem or some surgeon's perspective which went wrong eventually. 6 months વાંધો ના આવ્યો, but at one fine day it dislocated. So we were worried that how would we remove it, but eventually what I did is with the help of artery, I tried to push it towards the medial side and then I removed it from the between the condyle and the medial side and made it vertical, and I could not very difficult to remove it, but eventually I removed it. And then what I did was, because I had to open it, I opened it, and this is a video showing that after the same poly, not even a bigger poly, the same poly, Chirag, the same poly, it never dislocated. All kind of maneuvers, whatever I did. But Dr. Alpesh rightly pointed that it was an overcorrected knee, and if I could then put my leg, it was almost a neutral and going little bit in valgus. So I did not want to do commit another insult. I can put the same poly or maybe a bigger poly, and then eventually after 5 years I did not want to have a lateral compartment arthritis and an unhappy Surti patient. So eventually I decided that I would go for a knee replacement, total knee replacement. But sometimes these dislocations are, so removal was very easy as Oxford, keels are not very big, and we can just manage with a normal TFC implant. If at all you required, you can have a short rod or sometimes an augment. You don't need a semi-constrained kind of thing. So somebody did a nice literature survey of understanding how the dislocation happens. So they understood 67 dislocations, and they tried to see, the most common is component malposition, where the rotations are abnormal. The another one is if you are small in tibia, so then it can go posteriorly, and if your flexion gaps are too tight, then the problem would occur. So gap balancing, component rotations, most of the time I would say it is a surgeon's fault. Very rarely it is patient's own problem. But yes, if you do a very nice proper balancing and everything, I think this is, as he said, 0.1% of chance of mobile bearing dislocation. Thank you very much.